Welcome to the Deep Dive. Today we're tackling something really important, a condition often called, well, the silent killer. Because it often gives, almost no warning, just quietly does damage. We're talking about hypertension, high blood pressure.
Right.
It affects, nearly half of all adults, and it's a major, major risk factor for serious stuff like heart attacks and strokes. But it is modifiable.
That's the key point. And our mission today really is to give you, our future nursing students, a solid, practical understanding of it.
Okay.
We'll walk through how blood pressure is normally regulated, what goes wrong in hypertension, how it shows up or doesn't show up.
Right, the silent part.
Exactly. Then the diagnostics and, crucially, the nursing management. Lifestyle, meds, even crisis situations. We want to connect all those dots for your practice.
Excellent. So let's start right at the beginning. What is blood pressure, fundamentally? I like the plumbing system analogy.
Yeah, that works pretty well. BP is basically the force blood puts on the artery walls as it flows through. You need enough pressure, but not too much.
And the sources say it boils down to two main things: cardiac output and systemic vascular resistance.
Precisely. Cardiac output, or CO, is how much blood your heart pumps out each minute. Think stroke volume times heart rate.
Okay.
And systemic vascular resistance, SVR, is the opposition that blood faces as it flows through the vessels. The main player here. The radius of the small arteries, the arterioles. Even a tiny bit of narrowing there can dramatically increase SVR. Like stepping on a hose, Pressure goes way up.
Gotcha. And the body has ways to control this, right? Short-term and long-term.
Absolutely. Short-term, like second-to-second, hour-to-hour adjustments, rely heavily on the sympathetic nervous system, the SNS.
Fight or flight system.
Sort of, yeah. If BP drops, the SNS releases norepinephrine, which makes the heart beat faster and stronger, and constricts blood vessels, all to boost that pressure quickly.
Okay, and what about baroreceptors? I read about those.
Critical players. They're nerve cells in your big arteries, carotid and aorta, that sense stretch, basically sensing the pressure.
So they tell the brain what's happening.
Exactly. If pressure's high, they signal to slow the heart, dilate vessels. If it's low, they signal the SNS to step things up. But here's a really important point for nurses.
Okay.
In people with chronic hypertension, these baroreceptors can actually reset to that higher pressure. They start seeing it as the new normal.
Oh, wow. So the body stops trying to lower it as effectively.
Pretty much. It makes it harder to manage. And don't forget the vascular endothelium, that single layer of cells lining the blood vessels.
Right, involved in vasodilation and constriction.
Yes, it produces substances like nitric oxide to relax vessels and endothelin to constrict them. Damage from things like smoking or high cholesterol can mess up this balance.
Okay, so that's the quick stuff. What about the long game?
That's primarily the kidneys, the renal system. It controls blood pressure long-term, mainly by regulating sodium and water balance.
More salt, more water, higher pressure.
In essence, yes. More sodium leads to more water retention, increasing your extracellular fluid volume, which directly increases cardiac output and BP.
And this is where RAAS comes in, the renin-angiotensin-aldosterone system. Sounds complicated.
It is, but it's crucial. When the kidneys sense low BP or get SNS signals, they release an enzyme called renin.
Right.
Renin starts a chain reaction. It leads to the formation of angiotensin I, which is then converted to angiotensin II, or A through.
And AAC is the important one.
Very. It's a super potent vasoconstrictor, so it directly increases SVR, raising BP quickly. But it also acts long-term.
So.
It stimulates the adrenal glands to release aldosterone. And aldosterone tells the kidneys to hang on to sodium and water.
So it increases both resistance and volume.
You got it. It's a powerful system for raising BP. Thankfully, the body also has countermechanisms, like natriuretic peptides that help excrete sodium and water. It's a constant push and pull.
A delicate balance, definitely.
Yeah.
So what happens when that balance gets thrown off consistently? That's hypertension.
That's hypertension, and we classify it based on the readings. For adults, normal BP is less than 120 systolic and less than 80 diastolic.
Okay, that's the goal.
Right. Then there's elevated BP, 120 to 129 systolic, and still less than 80 diastolic. Not quite hypertension, but a warning sign. Stage 1 hypertension is 130 to 139 systolic or 80 to 89 diastolic. And stage 2 is 140 or higher systolic or 90 or higher diastolic.
And it's the higher number that counts.
Exactly. Whichever reading, systolic or diastolic, falls into the higher category determines the stage. And critically for diagnosis, you need multiple elevated readings on separate occasions. One high reading isn't enough.
That makes sense. Now, I read there are two main types, primary and secondary.
Correct. Primary, sometimes called essential hypertension, is the vast majority, like 90–95% of cases.
And we don't know the exact cause.
Not one single cause, no. It's multifactorial. Genetics play a role, diet, lifestyle factors like stress, alcohol, endothelial dysfunction, lots of contributing factors.
Okay. And secondary.
That's the other 5–10%. Here there is a specific identifiable cause, things like kidney disease, sleep apnea, certain endocrine disorders, even some medications.
And you'd suspect that if someone suddenly gets really high BP.
Exactly. Sudden onset or very severe hypertension should make you think about secondary causes because often treating the underlying cause can fix the hypertension.
Got it. So focusing on primary hypertension, what's the main physiological issue?
The hallmark really is a persistently increased systemic vascular resistance, SVR. Those blood vessels are just staying too constricted.
And why does that happen?
Again, multiple factors. There's often a genetic component like sensitivity to salt. Some people's BP goes way up with sodium. This seems more common in Black individuals and older adults. Alterations in that RAAS system we talked about are common. Maybe too much renin activity. Chronic stress keeps the sympathetic nervous system fired up, leading to vasoconstriction. Insulin resistance is linked to, and that endothelial dysfunction, the imbalance of vasodilators and vasoconstrictors.
It sounds like a complex web of factors.
It really is, which is why management often needs to address multiple angles.
Let's talk risk factors then. What puts people at higher risk?
There are quite a few. Age is a big one. Systolic BP tends to climb as we get older. Lifestyle's huge. Too much alcohol, smoking, or tobacco use. Not enough physical activity.
Diet too, I assume. High sodium, high fat?
Definitely. High sodium intake, obesity, high cholesterol, or lipids all contribute. Diabetes is a major risk factor as well.
What about things people can't control?
Ethnicity plays a role. Black individuals tend to develop hypertension earlier, have higher rates, and more severe complications. Family history is important. And socioeconomic status impacts everything from diet to access to care and stress levels. Gender differences exist too, changing across the lifespan.
It's a lot to consider.
Yeah.
And the scary part is you often don't feel any of this happening, right? That silent killer nickname again.
Precisely. Most people with primary hypertension have no symptoms, especially early on. Symptoms usually only appear when it's severe or when target organ damage has already started.
What kind of symptoms might show up late?
Maybe things like fatigue, dizziness, palpitations, shortness of breath. But they're vague, Could be lots of things. Headaches and nosebleeds aren't reliable signs of chronic hypertension, though they can happen in a crisis.
So the real danger is the long-term damage.
Absolutely. That's the target organ disease. It hits the heart, brain, peripheral arteries, kidneys, and eyes.
Let's break that down. What does it do to the heart?
Well, it's a major driver of coronary artery disease, hardening of the arteries. Plus, the heart has to pump against that high pressure constantly.
That sounds like hard work.
It is. The left ventricle, the main pumping chamber, compensates by getting thicker. That's left ventricular hypertrophy, or LVH.
Is that bad? Thicker sounds stronger.
Initially, it helps, but eventually that thick muscle needs more oxygen, becomes stiff, and can't relax properly. Ultimately, it leads to heart failure. The heart just can't keep up.
Wow. Okay, what about the brain?
Big risk for stroke. Hypertension damages brain arteries, leading to atherosclerosis there too. The risk of stroke is like 4 times higher, even with mild hypertension. And in severe cases, you can get hypertensive encephalopathy.
It sounds serious.
It's a medical emergency. A sudden, severe BP spike causes brain swelling, leading to headache, confusion, seizures, even coma.
Okay. Peripheral vessels.
Same process. Accelerated atherosclerosis in the legs, aorta, leading to peripheral vascular disease, PVD. Think pain with walking, risk of aortic aneurysms or dissections.
And the kidneys. You mentioned they regulate BP.
They do, but they also suffer from it. Hypertension is a leading cause of chronic kidney disease. It damages the small blood vessels in the kidneys, nephrosclerosis.
Oh.
Over time, this can destroy kidney function, leading to renal failure.
How would we see that? Lab tests.
Yep. You'd look for protein or albumin in the urine, rising BUN and creatinine levels, indicating the kidneys aren't filtering properly.
And finally, the eyes.
You can actually see the damage. Looking at the retina with an ophthalmoscope shows changes in the tiny blood vessels narrowing, hemorrhages, swelling. It reflects what's happening systemically and can cause blurred vision or even vision loss.
It really affects the whole body. So how do we catch it before all this damage happens?
Yeah.
Diagnostics.
Right. The goal is to confirm the diagnosis, check for those secondary causes we mentioned, assess for any existing target organ damage, figure out overall cardiovascular risk, and get baseline labs before starting treatment.
What are the key tests?
Basic labs are crucial. Urinalysis, BUN, creatinine to check kidney function. Serum electrolytes, especially potassium, low potassium, might suggest hyperaldosteronism, blood glucose for diabetes, a lipid profile for cholesterol.
Okay.
An ECG, an electrocardiogram, is standard. It can show signs of LVH or heart strain, even old heart attacks. Sometimes an echocardiogram, an ultrasound of the heart, is done to get a better look at LVH.
And what about that white coat thing? People whose BP is high only at the doctor's office.
Yes. For that, ambulatory blood pressure monitoring, or ABPM, is fantastic. The patient wears a cuff that takes readings automatically over 24 hours during their normal day and night.
So you see what their BP is really doing.
Exactly. It helps identify true hypertension versus white coat. Plus, it shows the pattern. Normally, BP dips at night. Some people, non-dippers or reverse dippers, don't have this dip, or their BP even goes up at night. That signals higher risk.
Really helps tailor treatment then.
Immensely.
And as nurses, getting an accurate BP reading seems fundamental.
Absolutely critical. Technique matters so much. Using the right cuff size, too small gives a false high, too large a false low. Proper arm position, supported at heart level, listening carefully for the sounds.
I read about an auscultatory gap.
Yes, that's where the sounds disappear for a bit during deflation and then reappear. If you don't pump the cuff high enough or deflate too quickly, you might miss the true systolic pressure and record it as much lower.
So being meticulous is key. And trends are important, not just one reading.
Definitely. Always look at the trend. Also, checking for orthostatic hypotension, measuring BP and pulse lying, sitting, and standing is vital, especially in older adults or those on certain meds.
How do you check that?
You have the patient lie down for 5 minutes, take BP and pulse. Then sit up, wait 1-2 minutes, repeat. Then stand up, wait 1-2 minutes, repeat. A drop of 20 millimeter of Hg systolic or 10 diastolic, or a pulse increase of 20 beats per minute suggests orthostatic hypotension.
Good to know. And home BP monitoring.
Increasingly important.
Yeah.
But patients need guidance on using validated devices, proper technique, consistency in timing, and keeping a log. It empowers them and gives us valuable data.
Okay, so once hypertension is confirmed, what's the plan? Lifestyle changes first.
Always. Lifestyle modifications are foundational for everyone with elevated BP or hypertension. Think of the Life's Simple 7 from the American Heart Association.
Wait, sure.
Manage BP, control cholesterol, reduce blood sugar, get active, eat better, lose weight, and stop smoking. Simple goals, powerful impact.
Does weight loss really help much?
Significantly. Even losing a moderate amount of weight, say 10 pounds, can noticeably lower BP. The general rule is about 1 millimeter Hg drop for every kilogram, or roughly 2.2 pounds, lost.
Wow. And diet.
Huge. Plant-based diets, the Mediterranean diet, and especially the DS diagram, dietary approaches to stop hypertension are proven to lower BP. They're rich in fruits, vegetables, whole grains, lean protein, low in saturated fat and sodium.
Sodium. The big one. What are the targets?
General recommendation is less than 2,300 milligrams per day. For even greater BP reduction, aim for less than 1,500 milligrams. The challenge is hidden sodium.
Like in processed foods.
Exactly. Breads, lunch meats, pizza, canned soup, sandwiches, even poultry, the salty six. Patient education on reading labels and cooking fresh is key.
What about alcohol and exercise?
Moderate alcohol use is the guideline, generally 1 drink a day for women, up to 2 for men. Excess definitely raises BP. For activity, aim for at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic activity per week, plus muscle strengthening.
And smoking.
Absolute must quit. Nicotine causes vasoconstriction, raises BP, and is a massive risk factor for cardiovascular disease overall. Cessation is critical.
And we also need to consider social factors, right? Stress, access to care.
Absolutely. Social determinants of health play a massive role. Stress management, ensuring access to affordable, healthy food and health care, addressing socioeconomic barriers. It's all part of holistic nursing care. Screening and referrals are important.
Okay, so lifestyle is step one, but sometimes that's not enough.
Often, yes. Or if the BP is very high initially, medication is needed alongside lifestyle changes.
What's the goal with meds?
Generally, to get systolic BP below 130 millimeter Hg for most adults, although specific goals vary based on age and other health conditions. The drugs work mainly in 2 ways, reducing blood volume or reducing systemic vascular resistance.
Let's touch on the main classes, diuretics.
Often first line, especially thiazide diuretics like hydrochlorothiazide, they make you excrete sodium and water, lowering volume. Key nursing points. Monitor potassium levels, watch for orthostatic hypotension.
Okay, then the ones that affect that RAS system, AC inhibitors and ARBs.
Right. ACE inhibitors like lisinopril block the conversion to angiotensin II. ARBs, like losartan, block angiotensin II from binding to its receptors. Both reduce vasoconstriction and aldosterone release.
What's the main difference for patients?
ACE inhibitors can cause a persistent dry cough in some people. If that happens, an ARB is usually a good alternative as they don't typically cause cough. Both require monitoring kidney function and potassium.
Got it. Calcium channel blockers, CCBs.
Like amlodipine or diltiazem, they generally relax blood vessels, causing vasodilation, which lowers SVR. Some also affect heart rate, a key point. Grapefruit juice can interfere with some CCBs, increasing drug levels dangerously.
Good tip. And beta blockers.
Like metoprolol, they primarily reduce heart rate and contractility, lowering cardiac output, also reduce renin release, very important. Use cautiously in asthma patients, and they can mask symptoms of low blood sugar in diabetics. Also, watch for fatigue or depression.
So how are these usually started?
For stage 1 hypertension, usually start with one drug, often a thiazide, CCB, ACE inhibitor, or ARB. For stage 2, treatment often starts with two drugs from different classes right away.
Two drugs. Why?
They often work better together, attacking the problem from different angles, and it can sometimes allow for lower doses of each, reducing side effects. Plus, combination pills, 2 meds and 1 tablet can really improve adherence.
Adherence seems like a big issue.
It is, and sometimes, even with multiple drugs, the BP stays high. That's called resistant hypertension.
What causes that?
It's defined as not reaching goal BP on full doses of 3 different meds, including a diuretic. Causes can be improper measurement, patient not taking meds correctly, volume overload, other conditions interfering, or even secondary causes we missed. It requires careful investigation.
So as nurses, especially in clinics or home care, managing this long-term is a huge part of the job.
Absolutely. It's about helping patients reach and stay at their goal BP, monitoring for effectiveness and side effects, and constant patient education.
What are the absolute must-teach points?
Explain their BP numbers. Stress that it's usually silent, no symptoms doesn't mean it's gone. Emphasize its lifelong management. Detail the meds, names, why they take them, side effects. Tell them never stop abruptly, risk of rebound hypertension, and don't double dose if they miss one.
What about common side effects, like dizziness?
Orthostatic hypotension is common. Teach slow position changes, dangling feet before standing, leg exercises when sitting. Sexual dysfunction is also common, especially with some drug classes.
That sounds like a difficult conversation.
It can be, but it's crucial. Patients often stop meds because of it. Reassure them it's common. Encourage discussion with their provider, as changing meds can often help. Don't let it be the unspoken reason for non-adherence.
Speaking of non-adherence, what else causes it?
So many things. Sometimes it's lack of understanding, low health literacy, side effects definitely, cost can be a huge barrier, or simply feeling overwhelmed. Sometimes if their BP improves, they think they're cured and stop taking the meds.
The sources mentioned a case, TB, a non-adherent patient.
Right, a good example. A 67-year-old man, stage 2 hypertension, not taking his meds reliably. Turns out his wife recently died, kids live far away, he's lacking social support, maybe depressed. It's impacting his routine, his motivation.
So it's not just about remembering the pills.
Never just about that. You have to dig deeper, understand their life context, their barriers, their beliefs. Then you can work with them to create a plan that actually fits their life. That patient-centered approach is everything for adherence.
That makes sense. Now, are there specific groups we need to pay extra attention to? Older adults?
Definitely. Hypertension is more common in older adults. They're also more likely to have that white coat effect.
And their bodies react differently.
Yes. Arteries get stiffer, the heart muscle might be thicker, baroreceptor reflexes become less sensitive, kidney function often declines. All this affects BP regulation and response to meds.
So more risk of side effects.
Generally, yes. Higher risk of orthostatic hypotension. Also increased risk of kidney injury from meds, and they can get postprandial hypotension, a drop in BP after meals.
Anything else specific to older adults?
NSAIDs. Non-steroidal anti-inflammatories like ibuprofen or naproxen. They can raise BP, counteract antihypertensive meds, and increase the risk of heart failure or kidney problems, especially if taken with ACE inhibitors, ARBs, or certain diuretics. Big interaction to watch for.
Okay, crucial point. Now let's shift to the most acute situation. Hypertensive crisis.
Sounds bad.
It is. It's a medical emergency, defined as systolic BP over to 180 and or diastolic over 120.
Is it always an emergency?
Not quite. We differentiate between hypertensive urgency and hypertensive emergency. Urgency is very high BP, but without signs of new or worsening target organ damage.
Yeah.
Emergency means there's evidence of acute damage happening to the brain, heart, kidneys, etc.
So the emergency needs immediate hospital treatment.
Absolutely. Usually ICU-level care. Urgencies can often be managed more slowly, sometimes outpatient with oral meds, but emergencies require immediate controlled lowering of BP, usually with IV medications.
What usually causes a crisis? Often it's patients with chronic hypertension who stop taking their medication abruptly, or they're undermedicated. Illicit drug use, like cocaine or amphetamines, can trigger it. Head injury, kidney disease complications, preeclampsia and pregnancy. Several potential causes.
And how does it manifest? What signs scream emergency?
Hypertensive encephalopathy is a big one.
Yeah.
Severe headache, nausea, vomiting, confusion, seizures, coma. Signs of rapid heart damage like severe chest pain, unstable angina or MI, shortness of breath from pulmonary edema, acute kidney failure, or signs of aortic dissection sudden, tearing chest or back pain, retinal hemorrhages or papilledema seen on eye exam.
Okay, so in an emergency, you're in the hospital getting IV meds. What's the goal? Just lower the BP fast.
Not too fast, that's dangerous. Lowering BP too quickly can actually cause ischemia to the brain, heart, or kidneys because perfusion drops too low.
So how do you guide it?
We often use the mean arterial pressure, or MAP, you calculate it, systolic BP plus 2 times diastolic BP, then divide by 3. The initial goal is usually to lower the MAP by no more than 20-25% in the first hour, or lower it to around 110-115 millimeter Hg. There are exceptions, like in stroke or aortic dissection, where goals might differ, but generally it's a gradual, controlled reduction.
What IV meds are used?
Usually potent, fast-acting vasodilators like sodium nitroprusside, nicardipine, clozapine, or adrenergic inhibitors like labetalol or esmolol. They require very close monitoring.
Which brings us to nursing interventions. What's key?
Intense monitoring. BP and heart rate may be every 2-3 minutes initially, often via an arterial line for continuous readings. Continuous ECG monitoring, hourly urine output to track kidney function, frequent neurologic checks, level of consciousness, pupils, motor function to watch for encephalopathy. Strict bed rest initially.
It sounds intense. And for urgencies?
Less intense, managed with oral meds like captopril, labetalol, clonidine. Close follow-up is needed, but usually outpatient.
Any specific drug alerts for crisis meds?
Yes, clonidine and labetalol, even oral doses used sometimes for urgency, can cause significant orthostatic hypotension. Teach slow position changes. And never stop them abruptly high risk of severe rebound hypertension, potentially worse than the initial crisis.
Okay, let's try that practical scenario. 68-year-old man in the ED, BP 210/118, severe headache, vomiting. What are you thinking?
Hypertensive emergency, definitely. The headache and vomiting scream potential hypertensive encephalopathy, acute brain involvement. Target organ damage is happening.
So immediate concerns.
Protecting the brain. Need to get that BP down, but carefully. Calculate the MAP. Let's see. 210 plus 2118, that's 2010 plus 236.3, 3446, 3 roughly 149 millimeter Hg.
Okay.
So the initial goal would be to lower that NAP by maybe 20%, down to around 119-120 over the first hour or so. Anticipate starting an IV drip, likely nicardipine or labetalol. Need intensive monitoring, arterial line, neurochecks, ECG, urine output. Assess for other target organ damage too. This needs immediate, careful action.
Really highlights the nurse's role in spotting and managing this.
Absolutely critical.
Wow. What a deep dive. We've gone from basic BP regulation all the way to managing a full-blown crisis. Covered the pathophysiology, the risks, the complications, diagnostics, lifestyle, meds.
That's a huge topic.
It really is. I think the key takeaways for you listening as future nurses have to be the absolute importance of accurate assessment, getting that BP right, recognizing orthostatic changes, monitoring trends. Plus, patient education is everything for long-term management, and knowing how to act fast and appropriately in a crisis.
Exactly. And remember, understanding hypertension isn't just about the numbers of the drugs. It's about seeing the whole picture, how this condition affects the entire body, why prevention is so vital, and how you can empower patients to manage it throughout their lives. You're going to be on the front lines of this.
So maybe a final thought for our listeners.
Well, think about this. We've talked a lot about the physiology and the meds. But how do those social determinants we touched on, poverty, access, stress, education, really intersect with a patient's ability to manage hypertension day to day? And looking forward, how might technology like apps or wearables change how we help patients stay adherent and monitor their condition? Something to keep thinking about as you move into practice.
Great points. Thank you for joining us on the deep dive. Keep learning, keep asking questions, and keep making a difference.